Hi everyone, this is Dr. Akgul. I'm a pathologist at Albany Medical Center. Today, I'd like to continue my urologic pathology installments, but I will do several things differently. First of all, as you can see, I will use English to reach wider audience. The second thing is it will be kind of a very brief summary approach on renal tumors with clear cell cytology. It's not going to be, a little detailed explanation of a single entity. Right now in this slide, you may think that you are looking at a map of New York City and neighboring states, but actually it is an analogy on how to approach kidney tumors. Right now, think about you are looking at a low power image of a renal neoplasm. So growth pattern will be important in identifying the tumor, whether the tumor shows SNR or nested pattern or solid component, whether there's a papilla or not, or micropapillary features or not. Is there any hypercellular area or alternating hypercellular or hypocellular areas? These will be important things that you should ask, or maybe presence of cystic component. These are the things that we search for with regards to understanding the type of the tumor. The other thing we look at is the vasculature, how it's organized, how its relationship with the tumor cells. These are also important features in renal tumors. When we look at the higher power, one of the things we do is to try to assign something called International Society of Urologic Pathology nuclear grading in certain tumors. Right now, it is validated on clear cell and papillary renal cell carcinomas, but it is something we do. And one of the tricks that that may facilitate your nuclear assignment is to look at the a little bit more pleomorphic in clear cell renal cell carcinoma eosinophilic areas to assign the nuclear grade. And lastly, you may want to use immunohistochemical stains, which is not a bad idea in kidney tumors, but if you throw everything at once, you will just confuse yourself. So morphology-driven approach should be the main approach in kidney tumors, like in any other parts of the surgical pathology. There's an article from 2014. It is a little bit older article now, but I think it is still one of the leading references in terms of how to approach kidney tumors. I strongly recommend this paper to our colleagues, particularly the trainee colleagues. When we think about kidney tumors with clear cell cytology, we have relatively limited set of differential diagnoses. And morphology-driven approach should be the primary thing. And I'm not going to go over with this information that is written here, but I like to go over with you a 4 questions with their answer. And I think by answering these 4 questions, it will be very easy for you to tackle with most of the kidney tumors with clear cell cytology. There are other tumors that are not listed here that may show partial or predominant clear cell cytology, such as epithelial angiomyolipoma or papillary renal cell carcinoma with clear cell cytology. And to be honest, you will be trying to find the first 4 on the left side when you encounter with the kidney tumor of clear cell cytology. So, these are clear cell renal cell carcinoma, chromophobe renal cell carcinoma, MIT family translocation renal cell carcinoma, and clear cell tubulopapillary or papillary renal cell carcinoma. Let's start with the first question. Is this a clear cell renal cell carcinoma? That is the most important question that we are going to ask in tumors with clear cell cytology, because that's what most matters for our urologic colleagues. Right now, the treatment availability is very high in clear cell renal cell carcinoma, and everyone wants to hear about that first. Clear cell renal cell carcinoma are composed of, well, clear cells, tumor cells with clear cell cytology, forming small nests. And also, as important as those small nests, you will have fine, delicate capillaries embracing those small nests. The vasculature, the architectural features of the vasculature is also important. Another important thing is carbonic anhydrase 9 and CK7 status of the tumor. Cytokeratin 7 should be negative. Carbonic anhydrase 9 should be positive, but how positive is also important. There will be diffuse and strong, crisp, membranous staining in clear cell renal cell carcinoma for most of the time. And also CD10 might be, CD10 will be positive with variable intensity. Our second question is there papillae formation? So there are exceptions, as always, but there are only two scenarios among these tumors when you will see a true papillae formation. These are MIT family translocation renal cell carcinomas and clear cell papillary or tubulopapillary renal cell carcinomas. Again, papillary renal cell carcinoma might have clear cell cytology, and there are rare reports indicating that there might be some true papillae formation in clear cell renal cell carcinoma. But if you encounter with a tumor showing clear cell renal cell carcinoma morphology predominantly, and you are questioning some areas about papillae, it is probably pseudopapillae. It's not the true papillae. MIT family translocation renal cell carcinomas, it doesn't have to be that way, but it is basically the most common renal cell carcinomas of the pediatric age groups, and younger patients may have more representation of these tumors when compared to the adults. But MIT family translocation renal cell carcinoma is still most commonly seen in adults, because renal cell carcinomas are common in adults, in elderly patients, when compared to the younger patients or pediatric patients. Classical features are composed of true papillae, epithelioid clear or eosinophilic cells, and occasionally some mammatose bodies. But please keep that in mind. Translocation renal cell carcinomas can look like anything. Cytokeratins, pan-cytokeratins, are reported to be underexpressed or negative, but they can be expressed too. Cytokeratin 7 is more consistently negative than other like pan-cytokeratins. The most important immunohistochemical stain is actually TFE3, showing the overexpression of this transcription factor in the nuclei. The problem is not all the labs are successfully performing that immunohistochemical stain. That's why there's a tendency to perform FISH rather than immunohistochemical assay of the TFE3. Clear cell papillary renal cell carcinoma is an indolent tumor. It is composed by tubules and true papillae. Actually, you see tubules more than papillae. That's why some of the authors, including me, thinks that I think the name should be clear cell tubulopapillary renal cell carcinoma. Carbonic anhydrase 9, like clear cell renal cell carcinoma, should be positive, and there is a pattern. You don't see that all the time, but there's a pattern of cup-shaped, which means the luminal tip of the cytoplasm or membrane will be negative, but the lateral and the basal part of the membrane will be positive. That's why they say that it's like, it looks like a cup shape. The other stain is cytokeratin 7. It should be diffusely positive. Remember, in clear cell renal cell carcinoma, it should be negative. So in clear cell tubular papillary renal cell carcinoma, cytokeratin 7 is diffusely positive. In clear cell renal cell carcinoma, it is negative. CD10 is mostly negative in clear cell tubular papillary renal cell carcinomas, but in the new kid on the block, renal cell carcinoma with angiolymyomatocytoma, they can really look like clear cell tubular papillary renal cell carcinomas. They tend to be positive for CD10. The third question is actually an immunohistochemical assay question. In my opinion, immunohistochemical assays should be performed liberally in kidney tumors due to well-known overlaps between recognized entities. Carbonic anhydrase 9 staining, as we previously discussed, should be diffuse and strong membranous staining in clear cell renal cell carcinoma. You will also see carbonic anhydrase 9 consistent positivity in clear cell tubular papillary renal cell carcinoma, multifocal cystic renal neoplasm of low malignant potential, an entity that I have never seen probably in real life, and renal cell carcinoma with angiolymyomatocytoma. The fourth question we are going to ask is the status of cytokeratin 7 expression. Chromophobe renal cell carcinoma, clear cell papillary renal cell carcinoma, and renal cell carcinoma with angiolymyomatocytoma will be positive with cytokeratin 7, whereas clear cell renal cell carcinoma and MIT family translocation renal cell carcinoma will be negative for cytokeratin 7. In conclusion, if you ask yourself those 4 questions, doing at least 2 immunohistochemical stains of carbonic anhydrase 9 and cytokeratin 7, you will be able to tackle most of the kidney tumors with clear cell cytology. That is all I want to share with you. Again, I told you it will be a very brief introductory approach in renal tumors with clear cell cytology. Thank you very much for listening, and please feel free to give your valuable feedbacks. Have a good day.